Good afternoon, every. Good afternoon, everyone. I didn't mean to step on the toes of our great graphics. Welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us this afternoon, and we are happy to continue in our journey, attempting to inform and educate and empower. As I have been reflecting on the state of our country, I have been thinking, and I'm specifically addressing the healthcare landscape. I could make comments about some of the others because I'm in Nashville, but as I reflect on the healthcare landscape, it seems to me that we all know that it's a troubled industry with problems with access, whether it's access to providers, access to medication, just across the board. And I don't see that situation improving anytime in the near future. So it seems to me we will have to work even harder to educate ourselves and empower ourselves to enable us to advocate for ourselves. And in the spirit of that, we're going to have a guest speaker today by the name of Dr. Randall Maxey, who is going to speak to us about how we can take care of our kidneys, because we are going to have to do a much better job of taking care of ourselves and knowing what we need to advocate for when we do have our encounters with our providers. So without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Neighbor-Stephens. Hello, Dr. Walks and Dr. Hines, and our wonderful technician, Mr. Simon Cooper. So the topic today is, of course, close to my heart, or close to my kidneys, if you will. And we know that the kidneys are the Achilles heel of the African American. So I'm going to take you through a few slides and just discuss some of the things that we can do to protect our kidney health. Simon, if you put those slides up for me. So let's go to the first slide after this. Go to the next slide. So my title is Kidney Disease in Black Americans. It's a very significant concern. According to the National Kidney Foundation, Americans, African Americans, are 3 times more likely to develop kidney failure as compared to their white counterparts. In the United States, kidney disease affects approximately 37 million people, with African Americans comprising a disproportionate percentage of those that are affected. Next slide.
I'm turning 30 tomorrow. I cannot believe.
So I describe this slide as a tragic smile. It's a map of the United States. And the dots that you see are the small area analysis of every zip code in the United States where the rate of renal failure, diabetes, and hypertension is more than 50% of the normal. So if you want to build a dialysis unit in the dialysis business, you would do it along this tragic smile, southeast, southwest, and west of the United States. Next slide, please. There are major risk factors for kidney disease. One is hypertension. 2 is diabetes. 3 is family history of kidney disease. 4 is obesity. 5 is smoking. If you're over 60 years of age, and if you're Black, Hispanic, Native American, or Asian American, we all have a higher risk of kidney disease. Next slide. The incidence of kidney disease varies along racial lines. According to the U.S. Renal Data System, the African American is about 3.5 times more likely to have kidney failure, kidney disease, than are white Americans. Go to the next slide. Here we show that most people, before they end up with end-stage renal disease or dialysis, probably die. We know that the major cause of death with kidney failure, chronic kidney disease, and ESRD is not the kidney failure itself, but it is the cardiovascular complications that precede it, including heart attack, stroke, pulmonary embolism, and the other things that may cause death. So most people don't even get to dialysis, they die before. And we don't necessarily equate that with kidney disease. Next slide. So chronic kidney failure, known as end-stage renal disease, is the final stage of chronic kidney disease. At this point, kidney function is so severely impacted that the only treatments available are either dialysis or a kidney transplant. And dialysis is a method of cleaning your blood of waste products so that you can live. It's an artificial way of urinating. Next slide. There are several genetic variants, APOL1 and APOL2, and these may play a significant role in kidney disease among Black Americans. These gene variants are common in individuals of African ancestry and have been associated with an increased risk of kidney diseases. This includes focal segmental glomerulosclerosis, HIV-associated nephropathy, and hypertensive nephrosclerosis. So when other people have these diseases, they don't get kidney failure at the same rate that African Americans do. Next slide. These 2 gene variants impact renal disease in Black Americans by increasing their susceptibility to kidney disease. The presence of these variants may contribute to disparities observed in the prevalence of kidney disease. It's very important that we address these. Of the 700,000 people on dialysis in the United States, more than 40% of them happen to be Black, even though Blacks make up 13% or so of the US population. They make up 40% of the dialysis population. Next slide. Can you go to the next one? So there's a test that we do when we want to know kidney function is called the estimated glomerular filtration rate. Until recently, they used a race factor, and this underestimated the renal function in Blacks. So there's been a lot of debate within the medical community why we can't eliminate that. But if we do eliminate it or modify and take that race factor out, it could improve the accuracy of kidney disease diagnosis and treatment of African Americans. So that has been essentially removed now. Dr. Keith Norris and others have led the fight to get that changed and taking the racism out of measuring kidney disease. Next slide. There are some important medications that you need to know about, and also some dietary issues that can slow the progression of kidney disease in hypertensives and especially diabetics. The first class is angiotensin receptor blocking agents, ARBs. These are medications that may relax blood vessels and lower blood pressure. These include drugs that end in the word sartan, like losartan. And those are the ones that we start first-line treatment with. And I usually put patients on a medication called losartan, and I might add another calcium channel blocker, such as amlodipine. And those two are the basis of the treatment. They treat the renin-angiotensin system. The next set is exemplified by a drug called Ozempic. There's another one called Majoram. And these are very valuable in people with type 2 diabetes. They can control blood sugar, lower your A1C, but more importantly, they decrease the pressure inside the glomerulus of the kidney. They might also increase weight loss. In fact, they've been approved by the FDA as a weight loss drug, so they're in short supply with everybody trying to get ready for summer and get in their bikini. Next slide. There are several other drugs that are important. I'm using brand names. I don't work for the companies, but the brand names are important because you'll see them. There's one called Farxiga, which is another type 2 diabetes medication that lowers your blood sugar levels and has been shown to reduce the risk of kidney disease progression and also decreases the heart disease progression and stroke decrease. So that's a very important drug, and you should know that name. A newer medication is called Kerendia, and it's a mineralocorticoid antagonist and specifically designed to decrease chronic kidney disease. Because another factor besides just the high blood pressure that exists within the glomerulus of the kidney, but there's something called inflammation. And this addresses that inflammation in the glomerulus and reduces that. Next slide. When you go to your doctor, it's important that they take urine. And in that urine, we measure the albumin. And we do an albumin to creatinine ratio, or ACR. And that number needs to be low. That will indicate whether or not these medications will help you. Usually when you have kidney disease, you start to have leaking of protein into the urine. You can practically tell that if when you urinate, there's a lot of foam in the toilet bowl. Protein in the urine makes foam. The other thing that the doctor needs to order is an estimated glomerular filtration rate. With those two things, we can make certain presumptions and make the treatment available to you. Next slide. So in addressing the major drivers of kidney disease, and I'm focusing now on type 2 diabetes since there's so many, and diabetes makes up a large number, maybe 40+% of all the people on dialysis, chronic kidney disease. So if we look at this, the first circle shows you need to have hemodynamic control, control of your blood pressure. I've had patients go to hospitals with providers that don't look like us, and they'll tell them, your blood pressure is 150/80. That's okay for you. Blood pressure for Blacks can be a little bit higher. That's not true. Their pressure needs to be below 120/80. So we need to have that. And we know that when that number goes down, you're more than 15 to 45% have less chance of having the complications of stroke, heart attacks, etc. The other thing you need to do is to lower the glomerular pressure inside the kidney. And you also need to have metabolic control. So we look at metabolic control in renal and diabetes of having a hemoglobin A1C of less than 5.9. So that's very important. And if you look at the middle picture with the kidney, it says that you want to control the inflammation that happens in the glomerulus. Until recently, maybe less than a year ago, there was not a specific drug targeted for that, but now there is. Next slide. So this drug is called finerenone or Kerendia. And this drug specifically decreases the inflammation inside the kidney and decreases the fibrosis of the scarring inside the kidney. So we know that these mineralocorticoid antagonists with a non-steroidal MRA stop progression of kidney disease in people with diabetes, especially, but other people as well. Next slide. So there are also some very important foods that can help prevent and protect your kidney disease. Antioxidants, we know. So if you consume foods that are rich in antioxidants, such as fruits, green leafy vegetables, this can help protect the kidneys because of oxidative stress. And this counters oxidative stress. But also, recently it's been shown that adding fatty fish, such as salmon, mackerel, and my favorite, sardines, to your diet provides omega-3 fatty acids, which can decrease the inflammation of those kidneys, just like Kerendia. Now, it's interesting that the omega-3 fatty acids in fish provide this protection, but the omega-3 fatty acids from plants do not. So it's important to add fish to your diet, especially cold water fish. Next slide. So we know that kidney disease is a major concern. And we know that understanding how these genetic variants is going to be critical how we address kidney disease in the future. Next slide. In this triangle, we show that for some patients early on, you want to start them on antiplatelet medication, anticoagulants. The 81 milligrams of aspirin is one. Some people use Eliquis. These help prevent strokes, blood clots, etc. For most patients, we start them with what we call the RAS blockers, angiotensin receptor blocking agents. Now, some people use ACE inhibitors, but I don't use ACE inhibitors in Black people. One, they weren't clinically studied in Blacks, and they cause more complications in Blacks, such as cough. They also can cause severe strangulation, I'll call it that, but it's an effect inside the tracheal tube and cause problems. There's also drugs that are called SGLT2 inhibitors, and those are ones such as Ozempic, but also use the SGLT2/1 inhibitors, such as Ozempic. We know that looking further down on the triangle, that there needs to be adequate glycemic control, adequate blood pressure control, and control of lipids. So we put people on statins to control those lipids. And those numbers need to be low. You don't want your LDL cholesterol to be high. You don't want your triglycerides to be high. For everybody, they need to exercise, even if it's only walking. And walking is probably the best thing that you can do. You want to make sure that you have adequate and good nutrition, green leafy vegetables, antioxidants. And we also want you to stop smoking. Smoking damages blood vessels. It's something, the dumbest stuff you can do is to smoke cigarettes. Next slide. And that goes for anything you smoke, not just tobacco cigarettes, but what people call those good green cigarettes. You have to stop those too as well. Nothing wrong with pot, but drink it, eat it, but don't smoke it. Next slide, please. Is there another slide, Simon?
I think that's it.
Okay. So the key takeaways from here, one, another risk factor is pain medication. Aspirin, ibuprofen, opioids, these all cause chronic kidney disease and ultimately kidney failure. We know that you need to stop smoking, and even being around smoke, secondhand smoke, is dangerous. And we think that these things, eating fatty fish, eating vegetables and antioxidants, can help decrease your chronic kidney disease. I thank you for your time, and I'll be glad to entertain any questions or comments.
Well, Dr. Maxey, you addressed primarily type 2 diabetes and touched on the cardiovascular issues created by that, as well as the damage done by high blood pressure without diabetes. But there is another condition that is disproportionately present in the African American community, and that's systemic lupus erythematosus. Could you speak a bit about the nephritis? I mean, you may want to explain the disease in the first place, but specifically the nephritis aspects as we see in SLE.
Good. So systemic lupus erythematosus is a collagen vascular disease. It's a disease of the immune system, where the immune system essentially attacks its own body. And specifically, the kidney is very vulnerable to lupus. And the lupus destroys part of the glomerulus, and it puts something in the kidney called subepithelial deposits along the basement membrane of the kidney. And by doing this, it makes protein leak into the urine. That leaking is a sign of that blood vessels being porous, being damaged, and that can lead to kidney failure. The initial treatment is with corticosteroids to try to stop that inflammation. And I do believe drugs such as the Corindia, which will also treat those with mineralocorticoids, non-mineralocorticoids, will affect that and cure that. Lupus can affect every organ in your body. It's usually diagnosed by having something positive called the anti-nuclear antibody, or the ANA, and your doctor or rheumatologist can diagnose it with a simple blood test. But it's a very dangerous disease, can affect your eyes, your heart, and your kidneys. And it does happen more in Black women than in white women. And female variants seem to be the most important with lupus, but I have seen it in males. We also do, in addition to looking at the ANA, we do a kidney biopsy so we can look at it under a microscope, and in particular under electron microscope, to make that diagnosis and treatment. Thanks for that question, Doctor.
One more and then I'll be quiet. Would you speak to the kidney complications seen in sickle cell anemia and speak to the confusion around the impact of sickle cell trait?
Okay, sickle cell anemia and trait. So the sickle cell anemia is called AA disease. When you do a hemoglobin electrophoresis, you have two of the sickle is dominant. But the trait, which is SA disease, is actually more dangerous for the kidneys than is sickle cell disease itself. We know that sickle cell is good if you're in Africa and trying to avoid getting toxic with malaria, because those sickle cells are more resistant to those parasites. But if you're here in the United States where we're not fighting malaria, it's not a good thing. The kidney disease in a lot of people is affected by these clumps of red blood cells being malformed and affecting the glomerulus of the kidney and can cause kidney failure. But there's more danger with SA or trait for the kidneys than there is of the AA disease or sickle cell disease itself. And there are treatments now out. And one of the treatments is L-arginine, which affects the pulmonary. One of the problems with sickle cell disease is pulmonary hypertension. And we know that that the L-arginine releases antioxidants that can affect pulmonary hypertension, which is one of the complications of sickle cell. But again, trait is worse than sickle cell disease itself.
We have a question in the chat. How often should a 65-year-old have her A1C tested? And are the A1C home test kits reliable?
I think they are reliable, but I would rather go to a bona fide laboratory to make sure that my A1C is less than 5.9. And for a 65-year-old lady, which is quite young, you're a young chick, your hemoglobin A1C should be tested at least twice a year. Now, in my patients, I tend to do it 4 times a year, at least quarterly, to make sure that number is down. The reason A1C is so important is called glycosylated hemoglobin. If I can give you a practical example, there's a dessert that I used to like called, what's the dessert, Dr. Neighbor? They put the glaze over the top of a custard?
Creme brulee.
Creme brulee. Well, that glaze is similar to the A1C. The way they make that glaze, they put sugar on top of a custard, and they take a blowtorch and they turn that sugar into a plastic glaze. So if you can imagine that if your blood sugar is higher than it should be, your body temperature of 98.6 is the blowtorch that turns that sugar into the plastic glaze. And those little spicules of plastic get into your blood vessels, they form plaque, they penetrate the blood vessels, and they cause atherosclerosis, they collect garbage, and they cause the vascular disease. We know that diabetes itself is a vascular disease more so than the disease of high sugar. But the high sugar results in that vascular disease that causes stroke, heart attacks, kidney disease, and all the above.
All right. I don't see, oh, no. How often should the lipid panels be tested in a patient that tends to have elevated LDL, but is trying to control with diet and exercise?
Well, I think that's admirable to control it that way, but if you're not controlled, that LDL in particular can kill you, and it can cause a heart attack. You do not want to get a plaque. So you want to see your nephrologist or cardiologist and see what your calcium score, because calcium score tends to be high. And people that develop plaque and that plaque gets calcinated, by your high calcium. Now, one of the things that we know in kidney disease, especially chronic kidney disease, end-stage renal disease, it affects your calcium, your magnesium, and it affects your parathyroid hormone. As that calcium goes up, your PTH goes up, and that calcium can be deposited into your skin, which causes itching. It can be deposited into plaque in your blood vessels, cause hardening of the artery, and ultimately can help occlude the coronary arteries, can cause problems with heart attack, angina, et cetera. So I would say you want that checked at least twice a year, if not more.
All right, I don't see any other questions in the chat. But I want to go back to something you just said when you made, in responding to that, you said you want to go back to your nephrologist or your cardiologist. But what about the person who does not have need of a cardiologist or a nephrologist? In other words, when we go to our PCPs, what is it that we need to be asking about and requesting that? What tests should we be directing to the PCP for them to obtain during our regular PCP visit?
Well, during your visit, you want to check your blood work, your hemoglobin A1C. You also want to have a chemistry panel done, which looks at your calcium and all those. And I would also ask for my parathyroid hormone to be taken. More importantly, you want to look at your urine. And that's a simple urine test. You just pee in the bottle and they can test it for the amount of protein. That would be the most important thing, making sure you're not having leakage of protein. And if you are having leakage of protein, you want to be on one of the medications or all the medications that I mentioned. Now, a lot of people want to be natural and they say, we don't want to take a whole bunch of pills. But if you have chronic kidney disease, and even more if you have chronic kidney disease secondary to diabetes, it is absolutely necessary that you be on a cocktail of drugs. And those drugs are the ARBs to control your blood pressure. They are the SGLT1s, such as Ozempic. You want to be on the SGLT2s, such as Farxiga. And you also want to be on the Kerendia type drugs. There's only one right now, the mineralocorticoid antagonist, to lower the inflammation. It is so important. You don't want to end up with a kidney transplant or dialysis. And those are important to do that. And in your diet, you want to add antioxidants, which are leafy green vegetables and legumes. And you also want to use fatty fish.
So now you need to get your pad and pencil out for this next question. Is the prevalence of chronic kidney disease in African Americans due to genetic factors or environmental factors or societal factors or a combination of factors? What is the weighted percentage of each factor?
I don't know that answer. So whoever asked that question must have the answer. Unmute them.
Simon,
I do not know those weighted percentages.
Simon, could you unmute Fred D. Sims, please?
Yes, thank you. Thank you very much. I find this really interesting, and no, I don't have the answer. I am concerned, though, whether this issue has arisen because of genetic factors dating back generations and has been on an increase, or is it because of the diets that are Black people have been subjected to and continue, or is it environmental factors such as pollution or stress that they're constantly under? And such stresses can cause, such micro stresses can cause changes within the body. And since Black people are typically under such stresses all the time, whether they know it or not in this society, or how has that come to play with the incidence of this disease?
Well, I thank you so much for the question. And with the exception of asking for the percentages, you're absolutely right. It's all of the above. And it's especially because of the genetics, that if you have African heritage, it may play a role in making your kidneys more susceptible. We know that the social determinants of health are susceptible. And part of that because we may have elevated levels of cortisol because of stress. And that leads to certain diseases that we talk about now. So all of those are extremely important in causing kidney disease and causing kidney failure and causing those things that affect our vascular system. But also more in line with what Dr. Walks, as a resident psychiatrist, does, we know that diabetes 2 can not only lead to vascular disease, but also affect obesity, but it also can lead to what's called diabetes 3, which is Alzheimer's disease. So it leads to cognitive defects in our group of people, and we want to be able to fight those. So all of those play a role. I just don't know the percentages that they play.
So there's a follow-up on that. Is the prevalence of chronic kidney disease seen in the same proportion in Africa and in other populations of Africans outside of the United States? If not, is it growing? And do you see an increase in CKD in Blacks that immigrate to the U.S.?
Interesting question. So I haven't been to Africa since 98. But when I was in Africa, and I was specifically in a country called Zimbabwe, there was not a significant number of diabetics with kidney failure, but there's a high rate of kidney failure because of high blood pressure. But as Western diets and foods have been globally put into these countries, you have more diabetes, more Alzheimer's, and more problems with your kidney disease. And a lot of it is diet. I was in Fiji some years before that. They had almost no diabetes, with the exception of people who lived and ate in the resorts. So a lot of it has to do with diet, and that diet has an effect to what we call the glutamate pathways on how it's handled by your ventral median nucleus, which is in your brain. And your brain, after something touches your tongue, tells the body where to put that energy source, whether it's going to be energy source placed around your midsection, which can lead to fat abdomen and have you shaped like an apple, versus a big butt, which is shaped like a pear. So it's all metabolic controlled by the brain, but it's also controlled by what you eat and which pathway that food tends to take. So it is an effect. In Western food, the diet that we eat from Europe and from here is negative for your body.
So continuing on the consumption train of thought, there's a question about what is your thought and or experience with cholesterol and red yeast rice herbal supplement that is sold over the counter?
Red rice yeast is good for you. It's good for the cholesterol. Most people don't necessarily go to health food stores, so I tend to put people on statins. They're a good drug. They do have some potential side effects. If you're having pains in your legs and cramps, then you need to stop it and find something better. But the use of red rice yeast is really good, and a number of other things can help take things down, but nothing good like a good statin to get people started. And then if they can control by diet alone, that's even better.
All right, I don't see any additional questions now in the chat. I don't know if Dr. Walks has made it back. I don't want to monopolize the conversation.
I have indeed made it back, and I do have a question for Dr. Maxey. So, Dr. Maxey, thank you, first of all, for this information. It is amazing the things that we are faced with. In terms of programs and working with departments of health, working with nonprofit organizations, how is it that you find those resources being used in our community?
Well, the biggest resource for kidney disease in our community is the National Kidney Foundation. And the Kidney Foundation is also the American Kidney Fund. They have tons of information at the patient level on how to take care of your kidneys, how to avoid kidney disease, and I would refer people to those things. But more and more, doctors have in their office information and literature that they can refer you to help guide your thing. But what we've been talking about for the past 3 years on the Black Health Trust is why your diet is so important. It's very important that you eat a diet that is high in minerals, iron, and things. That's why I prescribe most people prenatal vitamins, because we want to provide our pregnant women with the best vitamins. So prenatal vitamins to me are the best vitamins in the world. They're better than one a day and everything else on that. So everything we've said about keeping your vitamin D up, that's important. Keeping your vitamin C up, using selenium, etc., not using much salt. Those are all very important. And the resources you can find are from the National Kidney Foundation, American College of Cardiology, the Heart Association. They're all good sources of information.
So
So-
I won't cut you. Go ahead, Dr. Walks.
Sorry. So Dr. Maxey, we know that once we damage things, that the body tries to heal us. For example, we get a cut and it heals. When your kidneys are damaged, when we are in that kidney disease stage, other than going to see Dr. Maxey, how do we get things back to normal? Are we able to do it through diet, exercise? What's the best strategy?
Well, if you had asked me this question 10 years ago, I would have said, once you've damaged your kidneys, you're sort of stuck with where you are. And you want a slow progression of having worse kidney disease, but there is no real cure. But this being 2023, and we're looking at this new drug called Kerendia, which decreases the inflammatory process in the glomerulus. We're looking at that drug, which also decreases the scarring inside the kidney. And use of these SGLT2 drugs, there may be actually reversal of some of the chronic kidney disease. But we know that once the kidney is scarred to a certain point, it gets small and shrinks. And there's no cure for that. For example, people say, well, we've gotten a person off of dialysis. So one of the first research papers that I wrote showed that for people who got off dialysis, they shouldn't have been on dialysis in the first place, and they were misdiagnosed. And the way you can tell when you do a renal ultrasound or sound waves in the kidney, the size of the kidney sort of dictates the state of that kidney. If that kidney is small and shrunken like a walnut, you cannot cure it. If that kidney is still large or medium-sized, you can cure it or at least save it, and the person can get some return of renal function, if that answers your question. So right now, the jury is still out. We believe that for early chronic kidney disease, you can slow the progression, and some people may even have a reversal, but the jury is still out on those.
So Dr. Bean wants to know about African Americans and kidney transplantation access and prognosis.
Dr. Bean, you saying?
Dr. Bean.
Hello, Dr. Exelana Bean. One of the things I want to say, just for her sake, we know that in biopsies of blood vessels in infants who have no clinical disease, we can tell that who's going to get hypertension because they have thicker basement membranes. But looking forward to your question specifically, we know that the kidney transplant world has opened up, that there was one company that was handling all the matching and the disposition of kidney transplant from cadavers or from living related donors. That has now changed, and the Department of Health or Health and Human Service has now broadened that out. So a number of companies are in that field now. So there's a better chance that you can get a fair access at a kidney transplant now because of the loosening of that not being a monopoly with one company called UNOS. So it's a lot better process of getting a kidney. We know in the old days, if you had money, you could get a kidney, or if you're famous, you could get a kidney or a liver. But now everybody's going to be able to get kidneys.
So Dr. Maxey, go ahead, Dr. Walks, and then I'll say my question.
Oh, go ahead, doctor.
Well, I was just going to ask Dr. Maxey, as this is a holiday and we usually have family gatherings around holidays, what would you recommend to our audience that that should be brought up as we're sitting around gabbing around kidney disease in particular? But if you want to expand it to anything else, that's fine. But I hate for us to miss the opportunities that family gatherings give to further our understanding of what's happened with the family and hopefully influencing better outcomes in terms of the family's health.
Well, you almost answered your own question. I think family reunions, family dinners, when you see relatives that you infrequently see, it's important to know, what is my family history? And what did Aunt so-and-so have? What did Uncle so-and-so? What did my grandmother have? It's important that we all know what our risk factors are, whether it be high blood pressure, whether it be obesity, whether it be diabetes, whether it be lupus. We need to know what we're at risk for so that we can make appropriate adjustments. But even without knowing that, we know how important diet is. Important to eat a low-fat diet, how important it is to not eat so much red meat, how important it is to eat, I would say, I almost said greasy fish, I meant fatty fish, that we put those in our diet, that we use antioxidants, which are found in leafy green vegetables, that we use vitamin D. As we know, for those of us that are dark-skinned, we have less interaction with the sun to get through to cause vitamin D to be formed in our body. So that's important for our kidney health, but even for our prostate cancer health, it's important to do that. So use your family gatherings to find out your risk factors. That's very important, Dr. Nabor-Stevens.
Go ahead, Dr. Walks.
So Dr. Maxey, there are a couple of questions in the chat, and one of them in particular, I was talking with a patient of mine who has recurrent kidney stones. And can you say a little bit about kidney stones?
Kidney stones are caused by two methods. One method is hard water, or water that has a lot of minerals in it, such as calcium, and that can cause calcium stones, which are visible on x-rays if you take. Uric acid stones are not visible by radiology. But there's also, if you have a natural born tendency to form stones, the water that you drink doesn't necessarily affect that. So a lot of people have kidney stones, and kidney stones can be gotten rid of in some cases by what we call lithotripsy. Some are big enough to have surgery to get out, but they can cause significant damage. But where you live, there are certain areas called stone belts and it's based upon the nature of the water that you drink. But some people genetically tend to form stones in their kidneys. And for that, you do need a nephrologist, not a cardiologist, a urologist, actually.
And Dr. Sherrod has her hand raised, Dr. Maxey.
Hello, Dr. Sherrod.
Good afternoon and happy Resurrection Day to everybody. And thank you, Dr. Maxey, for such an outstanding presentation. A lot of good information. I was wondering if you could address a little bit about renal transplants. I know that we have a high rate of people going on renal dialysis, and I'm not sure that African Americans are utilizing or even know the indicators. How can you kind of talk about what are the indicators for deciding that you need to go on a transplant? Go on to transplant if you go on renal dialysis, and talk a little bit about the challenges that African Americans may face in trying to get renal transplant.
Okay, let's do a little statistic first. We know that there are about 700,000 people in the United States on hemodialysis or under transplant programs. Of that number of 700 plus thousand, we know that 40% are African Americans. So that's a huge number, a huge proportionate difference of that occurrence. A lot of places, if you live in West Podunk, Virginia, there's probably not a good transplant program there. But most Blacks tend to live in more urban city areas, and there generally are good transplant programs there. But we know there are disparities that if your physicians don't look like you, you may not have the same chance as being advocated for as white patients. So you may be less likely to know about or even get a fair chance at transplantation. We know now that there are two types of transplants that are available to people. The best absolute kind of transplants are the living related donor. That comes from a mother, father, sister, brother, or child. I tend to advocate that people do not accept kidney transplants from their children, because those kids are probably at the same risk or more that you were for getting the same disease years down the line. So it wouldn't be fair to take those kidneys. But mother, father, sister, brother, aunt, or uncle, those are good kidneys. The other type of kidney is cadaver kidney. And someone that died in a motorcycle accident or automobile accident, those kidneys are good. We do something called matching to make sure that they're the right genotype to go in your body without reaction. They've even found a way to get around that. If your relative doesn't have a kidney that matches you, they have banks now where you can trade the donated kidney in for somebody who does match you, and that evens out. So it does need to be, the kidney transplant is the absolute best we have to offer right now. In the future, we're looking at things like stem cells to help regrow some of those kidneys. That's not perfected yet, but people are doing research, including myself, to use stem cells to cure kidney disease, but that's in the future. I don't think it'll ever be done electronically, but it can be done biologically in the future, in my opinion. Thank you, Dr. Sherrod.
Well, Dr. Randall Maxey, we are at the top of the hour of this Resurrection Sunday. And I think we have done a pretty good job of covering some basic information around kidney disease. We'll be more than happy, and most likely will revisit this subject again in the future, because there were some areas that we did not get into today that we can get into, especially around pediatric kidney disease, which is a thing. So we will come back and revisit that. Dr. Walks, do you have any closing remarks?
I do have just a quick closing remark. Just just to give some words of appreciation to you, Dr. Neighbor Stevens, and to Dr. Maxey for starting us on this Black Health Trust journey, and to acknowledge how important it is that we continue to focus on our health. And on Resurrection Sunday, I just want to emphasize to so many of us that it's next Sunday, because I was ushering earlier today. Please don't come to church 20 minutes late and walk up to the usher and say, oh, there are 4 of us. Can you get 4 of us together? The answer is going to be no. Please come to church on time. Easter, Mother's Day, Christmas. Thanks again, Dr. Maxey.
Thank you, Dr. Moss. Dr. Stevens, you got final words?
Yeah, I do have a final word. We haven't brought it up at all in the course of this session, but this week I saw an article that I knew was going to be printed at some point or another. I didn't know when, but yes, we've got 2 new variants that are becoming rapidly increasing in prevalence in at least 16 states, and it's anticipated that they will continue to spread, and they have a higher level of transmissibility. They don't seem to be associated with as severe disease, but very easily transmitted, which brings me to the point that as we go around, don't forget the virus is still around, and you still need to wear your mask when you're in a setting where there is decreased ventilation and close proximity to your neighbor. Use your common sense.
Thank you so much, both of you, for being my partners over the past 3 years on this. And as my final word, Dr. Walks, I did go to church today. I was 15 minutes late, but I didn't ask to have 4 people seated. But I did enjoy the service. And it's very important that this is Resurrection Day. That has nothing to do with Easter bunnies and Easter eggs, but this is a day where our Lord and Savior created a major miracle of time and creation. That was suffering death for the remission of sins and rising as a miracle to sit on the right-hand side of God the Father Almighty. And in that sense, I want to wish everybody a happy, happy Resurrection Day. Enjoy your Sunday. Enjoy your life and your health. Thank you so much. Simon, have a good day.